And says good morning, everyone. I will say good evening to you, sir. Thank you so much for joining us. We are now live on Facebook, which is great. So we'll find out where everyone is. If you're watching us, again, Facebook is a public place. But if you want to share with us where you are at this moment in time, I would be delighted to read that. And any questions you have for Martin would be gratefully received. Professor Martin Weltman, Sydney, Australia. Good evening, sir. How are you?
I'm very good. I'm excited to be part of this Q&A and excited to be involved and happy to answer any questions.
Wonderful. Well, thank you very much. So we have questions that have been sent in already from some of our Australian patients. There'll be questions from UK patients. There'll be patients all around the world who contribute questions to this. So we'll see what comes. So we're absolutely delighted to have you here, and thank you for being part of this incredible worldwide service. So thank you. Okay, first question, if I may. The question is, can Professor Weltman recommend a diet if you have PBC, and would it differ for different stages of the condition?
Yeah, so there's no specific diet, but there's specific things you should perhaps consider adding to your diet or checking if you need to add to your diet, and there are specific dietary lifestyles one should avoid. And most importantly, today we're very aware of what we call non-alcoholic fatty liver disease. So people who are overweight and have a predisposition to diabetes or insulin resistance develop what we call the metabolic syndrome, this pre-diabetes state. And the fatty tissue that accumulates in the liver that may or may not be innocuous to someone who doesn't have an underlying liver condition is definitely much more likely to be something bad or something a little bit evil, for want of a better term, for the liver in our patient group. And I've seen these patients who have both fatty liver disease and who have as well a PBC. So they tend to develop much more severe and more aggressive disease. So the advice is to follow a healthy diet, high in fiber, low in saturated fats, and low in refined carbohydrates. So that's the refined sugars that we buy at the supermarkets and stores where we buy, the junk food type diets or the pre-manufactured carbohydrates. So we should keep those to a minimum, and they should be treats rather than regular things. So putting on weight is very easy as one gets a bit older, and PBC is more common as one gets a bit older. So that combination is not a good combination, and I would encourage people to be more vigilant with a healthy diet. Now, some people with PBC are vitamin D deficient and may need supplementation because there's a tendency towards vitamin D deficiency and active vitamin D in our patients with PBC. And as a precaution, patients should have their vitamin D checked from time to time. And it would certainly be quite reasonable to take some vitamin D supplementation.
Perfect. Thank you. That is most helpful. And it's interesting. So, we'll remember the old days where the biggest kind of crossover or overlap that we were concerned about was AIH, which is autoimmune hepatitis. But we now know that the overlap with fatty liver is actually way more common now. And it's something that we need to come to.
Absolutely correct. Yeah.
No, that's a helpful answer. So thank you. Thank you very much. Now, this is a great question, and this comes from documents that we as an organization have put out in terms of your URSO dose calculator and all of those kind of things. So the question we've been asked is, can you alter your URSO dose yourself, or do you need the doctor to okay it? But before we get to that question, can you maybe just talk a little about URSO dose and why we do what we do?
Yeah. So URSO dose, and I'm talking specifically about PBC, I think, you know, we sometimes make too much of an URSO dose, and most people will respond to even relatively low doses if they have very mild disease. Those with more aggressive disease or larger people, you'd want to give a higher dose. So it's you can either say it's a per body weight dosage, or more importantly, they just need a bit extra. And I would think you best to discuss that with your doctor and someone more familiar with your, even though it's a low risk thing to do. It's not a high risk thing to do, and it's not a dangerous medication, but one would hope you'd have a good relationship with your doctor and medical team that's looking after you, and it would be best to bring it up and discuss it with them.
Yeah.
There are people who have PSC or an overlap situation with primary sclerosing cholangitis, or have an overlap with PBC and PSC. And those people, you've got to be very careful about increasing your dose of ursodeoxycholic acid, because we sometimes use, it's quite widely used and it's used in different countries, but people use URSO in patients with PSC. And there's a study, a very important study that was done a few years back, that had to be abandoned halfway through when the Data Management Safety Committee looked at the data and showed that a higher dose was in fact more toxic in those patient groups. That it's quite the opposite in PBC. Increasing the dose may be beneficial to some patients, but I wouldn't get stuck. I'd be very careful, and if there's any mention of overlap with PSC, be extra careful. I would encourage you to talk with your doctor.
Okay, perfect. And that's, again, a great and helpful answer. And, you know, doctors are busy. They can be difficult to get a hold of, but actually this is absolutely 100% worth, you know, taking the time to make sure that you're asking your doctor the questions that you need to ask and all of those kind of things.
Yeah, and I'd like to add to that, if I could.
Please.
This is a long-term thing. It's not something you're going to go up and down with your dose usually. So it's a long-term change, and you should have your medical team on side. You want to have those good relationships, and you know, I would take, if I was really busy, I would take a message from a patient and say, "Yep, I'm happy with that," or "Not happy with that." You know?
Yeah, perfect. Okay, that's wonderful. Thank you for that. And so one of the things I didn't say right at the beginning was that what we're doing here is we are looking at general medical information. We're not giving anyone specific medical advice, and we are certainly not taking the place of an appointment with your own clinician. So happy to answer your questions as best we can, but hopefully those answers will then empower you to have the best conversations you can with your own clinician with regards to your own care. So I just wanted to highlight that. Martin, we have a good evening from, I'm going to say Launceston. Is that right? I have no idea.
Hi. Yes,
okay.
Launceston, perfectly right, yeah.
Okay, there you go. And we've got a good morning from Spain and a good morning from the UK as well. So just to let you know, that's where we are at the moment. So again, another URSO question. And again, it's great that these are coming in, because these are the absolute basics that we need to get right, in which, you know, and that starts the platform of your PBC care. So somebody obviously just starting URSO, and their question is, can I start off taking URSO slowly and build up the dose over a couple of weeks? I'd like to avoid any side effects and wondered if this helped your system get used to it. Any thoughts, Martin?
Yep. So it's not unreasonable to do that. There's certainly no downside to building up the dose. You don't really need to. It's generally a very simple drug, and if you're going to get side effects, you'd probably get a side effect from any dose. You wouldn't tolerate it, even a very small dose. That's the general principle. Yeah. However, if you want to build it up over 2 weeks, I certainly wouldn't see a problem with that. I don't think it's absolutely necessary, but there's nothing wrong in doing that.
Okay, perfect. That's helpful. So one of the things, and I don't know if this is in medical literature or if this is one of those things that the patient community knows I don't know. I'll share it with you and let's see where we go with this. But we often have people who start URSO, who may be a bit loose, maybe the runs, but that settles down. And I've always wondered, so URSO is a bile salt and it's responding with the bile that's in the liver.
Yeah.
And so if you have a level of bile in there and the URSO is doing what it's supposed to do, that actually, because you've only got one mechanism to get rid of that bile, that you can start to be a little loose until that bile starts to come down in levels in the liver. And again, I don't think that's often shared with patients who start their URSO and are forward. So sometimes it's, oh my God, I'm loose. That means the URSO is not responding, or a bad reaction to the URSO, when actually it's doing what we need it and want it to do.
Yeah, so I suspect that probably does sometimes happen. I haven't had anyone tell me that. I haven't had a patient come and mention that to me, but it does make sense. And I'd imagine you get used to it over a few weeks anyway. You wouldn't, that side effect shouldn't dwell on and last long term. But too many bile salts in the bowel and in the guts are going to cause a little bit of irritation and diarrhea if you overdo it. Yeah, it's not something that my patient group come across a lot, but it wouldn't shock me if people complain about that.
Yeah, and this is fascinating, and this is why I love the partnerships. And for those of you that maybe have never experienced Martin before, Martin and I will almost invariably meet on the floor at the poster section on PBC at either ASLD or ESO. I've seen him at APASO. And, these kind of partnerships with clinicians are really, really important because it brings everybody's knowledge together. I think over the years, we've established that patients have very, very different conversations with the patient support
that's true.
than they do with their clinicians. And so we have these interactions. It's great to bring the knowledge together so it's all in one place, which is fabulous. Okay, I have another question for you. So again, the background is I have been in pain since last year. My whole body aches. I cannot walk properly in the morning because of leg and foot pain. My hands are also swollen. Hand goes into spasm, and there's neck, shoulder, and back pain. Immunoglobulins are raised on 1,500 milligrams of URSO today. Now, her mum passed because of scleroderma, and obviously she's a bit scared that that could be the next part in her journey. So, any suggestions, any guidance, anything you could say to help?
Yeah, so I'm not giving you specific medical advice because we can't, but if I saw someone with those type of complaints, what would go through my mind is another autoimmune or connective tissue type disorder that people with PBC get Sjogren's syndrome, they get various forms of autoimmune arthritic illnesses. So we can get other autoimmune diseases that are associated with the genome that causes PBC, so that are closely linked on the genetic profile. And I would definitely be discussing that with my doctor to say, having that conversation, should we be looking a bit further? You don't often get it, but you sometimes get people with a broader autoimmune illness. And I've had to involve rheumatologists and immunologists with this care, with co-sharing my patients, and they sometimes find something extra. Furthermore, along those lines, you just need to discuss again with your specialist to make sure you don't have an overlap, and it's not that common, but the true overlap with autoimmune hepatitis, because you tend to get more systemic symptoms if you have an overlap type syndrome. So those are questions you should bring to your specialist that are worthwhile your specialist thinking about and considering. Yes.
Okay, perfect. That's helpful. Thank you. Right, I'm delighted. We've got live questions here in the room. We've got live questions on Facebook as well, which is fantastic. So we'll go through them.
Some questions written up, yeah.
Yep. So we've got a couple in here, and we've got a couple on Facebook, but we'll keep going. So here's a question: if platelets are over 200, does that mean that you don't have cirrhosis? And would it mean that you don't need an ultrasound? So those are two different questions. So we'll talk about platelets being 200 and cirrhosis, and then we'll actually talk about ultrasounds and the various scanning technologies that are available in the Australia and New Zealand, if that's possible.
Yeah. So let's talk about the platelets first. That's a very smart and intuitive question. I don't think I've ever been asked that previously, so I thank whoever asked that. It does make cirrhosis much less likely. It doesn't. You can have low levels of cirrhosis and have a normal platelet count, but it certainly makes cirrhosis much less likely. So it means that if you don't have cirrhosis, you're not at risk of liver cancer with this underlying disease. You're not at greater risk than the general population. So you wouldn't need regular ultrasounds for the purpose of looking for liver cancer, which is the most common reason we do it. If you have access to having a fibroscan, which measures the elastography in the liver using an ultrasound wave or any other form of shear wave elastography, and your score is low, you definitely don't have cirrhosis with that normal platelet count, and you definitely don't need to have regular ultrasound scanning. So I hope that helps you. With regard to ultrasounds, I only do regular ultrasounds on someone if they have cirrhosis of the liver, so they already have established cirrhosis, and we do that on a 6-monthly basis to screen for liver cancer because there's a significant increased risk of liver cancer. And we also measure a blood test called an alpha fetoprotein, which we abbreviate in our parlance as AFP. So we measure an AFP, and if it's rising, we would scrutinize that liver with further imaging in much greater detail, perhaps a multi-phase CT scan or a contrast-related MRI scan, or an MRCP, as we often refer that to. And if there's a lesion that's new on the liver, seen on an ultrasound, again, we'd go down that same pathway. Now, that's only done regularly in people who already have cirrhosis. The second thing is, we would use imaging sometimes for other reasons. So someone might have really a sudden disturbance in the liver test, and we think there's something new in the liver. We might go and image the liver, and that'll be decided. What's relevant will be decided by your doctor. So whatever's relevant will be decided by your specialist, which is the best imaging, and it depends on what imaging they have access to as well. Since we're talking about imaging, I'll refer to FibroScan. I'm referring specifically in Australia. FibroScan's not available. Most radiology practices, for example, wouldn't have FibroScan. But most big hospitals, certainly in New South Wales, and I would think it's similar in most states, would have a FibroScan machine. Where I work and the hospitals where I work closely by, we can refer just for a FibroScan. There may be a bit of a wait, but they get in and they do a FibroScan, which literally takes 3 or 4 minutes for most people. They get a bit of fast 3 hours beforehand. You come in and they put an ultrasound probe on the right-hand side over your liver between one of the rib spaces. And as long as you can get a straight line with an ultrasound wave, you can then get a FibroScan. And it's a matter of pushing a button, releasing an ultrasound wave, and receiving it back. And you have to push that button 10 times. And that doesn't even take a few minutes. It's very quick. Some people, we don't get an accurate FibroScan reading because they're very overweight, or their body habitus is that we can't get a straight line into their liver. But most people these days, we've got access to getting good quality FibroScan. And if your FibroScan reading is low, it means you don't have any significant fibrosis or cirrhosis, and you don't need regular imaging with ultrasounds, etc. If your FibroScan reading is very high, that implies you may have advanced fibrosis, and if it's very high, you may have cirrhosis, and there may be consideration for a liver biopsy in that context. So liver biopsies are sometimes used diagnostically, sometimes they're used prognostically to clarify someone's got cirrhosis, so they're at greater risk of an adverse outcome.
Yep. Okay, perfect. That's helpful.
I think I've covered it. Does that cover it? If
I think so.
haven't,
I think that's covered scanning technology and different types and different times to use them. So thank you.
Yeah.
Okay, so we have someone who's been diagnosed 4 years and stopped responding to urso. And we've got a question as to why that happened. So we'll bring that into this conversation as well. So first off, do we know why people stop responding to urso? Now they're on. Yep.
So we don't really know. That's the truth of it. We don't really know why some people do very well and stop responding. It's actually not that common. There's people who don't have a primary response, and again, we suspect they've just got more advanced disease. No one really knows properly how urso works. We've got ideas of how it works, and no one really properly knows how it works. We always say it's a good bile salt that's displacing bad bile salts, and the liver responds in a better way to that. And there's less cellular injury, there's less inflammation, etc. It's probably a bit more sophisticated than really that. But it's we love urso because it's a very safe drug. It mimics what we have in real life. So it's a great drug to have. The history of urso in Australia is it wasn't approved on our Medicare type pharmaceutical benefit system for many years. So patients couldn't get it or had to fund it themselves.
Gosh.
And it eventually got on through, most drugs have to get on through various drug trials, phase 3 drug trials, and they have to have a health economics analysis, and they need a series of consultants behind them, and it's a very costly exercise. Urso got onto the market eventually as an orphan drug based on the paper out of France that showed early introduction of this disease led to an improved outcome, and they went pleading that this was an orphan disease, a rare disease, and you couldn't do those type of studies. And that's how it got onto the PBS, really, to be quite honest, and was very fortunate once it got onto the PBS because it was a great boon for our patients,
So no, that's perfect. Okay, thank you. So somebody says, so back to this question where they stopped using urso. I am sorry, stopped responding to urso. Apologies. Been on Bezalip, and I'll ask you about second-line therapies in Australia in a second. But LFT is rising again. They have been taking iron tablets. Could that possibly affect their results?
Okay, so I think iron tablets are unlikely to be affecting your liver tests in any profound manner.
Okay.
Unless you've got hemochromatosis, which is an underlying iron overload disorder. So, if you haven't got that, iron tablets are going to be relatively innocuous. The first part of the question is second-line therapies. So, the only second-line approved therapy in Australia is, because bezafibrate's not available in Australia, we have to use other fibrates.
Okay.
And there is some data on fibrates and the use of fibrates to benefit the inflammation and in PBC. There's no fibrate. So if you use it in Australia, use it off-label, and it's supposed to be outside the Medicare system, although we have fenofibrate, and there's no studies of any note on fenofibrate. There are some studies on bezafibrate, which is Bezalip in some countries. It's not commercially available in Australia.
Okay.
So,
okay.
And so people use fenofibrate. I'm not a big fan of fibrates. I'm not anti-fibrates. The data to me doesn't look wonderful, but there are fans of fibrates. There are doctors who are real experts that are fans of fibrates, and they're low-risk tablets, really. So I've got, if one of my patients wanted to be on a fibrate, I would use it. Okay, there are descriptions of liver toxicity from fibrates, but that's rare and idiosyncratic, and has nothing to do with underlying PBC. So that's number 2. Number 3, in that regard, is today in Australia, and I'm talking to an Australian audience here, but I might be talking more broadly, we have obeticholic acid. And if your level of ALP is if you haven't responded or you have, so if you're intolerant to URSA, so you have side effects, I've yet to have that patient, fortunately.
Okay. Yeah.
Or you have an ALP level greater than 1.5 times normal. So for most labs in Australia, it's around 167 by our units. You qualify for obeticholic acid. So there's currently between 70 and 80 patients on obeticholic acid in Australia.
Oh, wow. Okay.
I suspect most of them truly need it. There might be some doctors who are prescribing it off-label, for other that don't fit those exact strict criteria. But we have to get an authority prescription from the PBS. And we start off at low dose once a day, 5 milligrams, and we are allowed to increase that if someone hasn't responded. I think I've forgotten, it might be after 1 month or 2 months to 10 milligrams a day.
Yeah.
You've got to know that the one rare side effect of obeticholic acid is itch or pruritus, which some people get from PBC. So most people at that low dose, in my experience, get an itch, and after a few weeks, it's gone. So they cope quite well with taking the obeticholic acid. As well, for non-responders, there's still newer drugs in drug trials, and it depends where you are. If you can access one of those drug trials, like we're involved with a novel agent, and we're not exclusive, the hospital I work at, and I'm a principal investigator on a drug trial for a new agent.
Fantastic. Well, that's good to know.
So we've enrolled 2 people at my center onto this new agent.
Okay, ideal. So, question then, in terms of clinical trial opportunities for patients in Australia, are they there and how do they get involved?
So they are there.
Yeah, okay, on you go, please.
No, and all they need is a referral to one of the trial centers. I don't think there's a central place where you can see if there's a trial, but we've over the last 7-8 years, maybe even longer, we've constantly had new drugs under trial at our center, which is Nepean Hospital, and we're not exclusive. We may have had a couple of centers sometimes in Sydney. For the current study, I think there's a couple of centers in Sydney. There's a couple in Melbourne, and there might be one in Perth and Adelaide and Brisbane. So there are centers offering the study. The only 2 patients in the study that have been enrolled at the moment are my patients.
Okay. All right. Okay. So, but there are opportunities there. All right. Thank you. And
all of the obeticholic acid study, in fact, they were all of the ones beyond phase 1, so phase 2 and 3 were done in Australia at multiple sites.
Perfect. Okay. Thank you. Next question. So somebody's saying they need a hernia operation, and in order to lose weight fast and short term, they're considering something like the Atkins or the keto diet. Now, we may have thoughts on that, and that's up to you if you want to say anything. But the question is, would this have any adverse effect on my liver?
So I'm not going to comment on the specific diets.
Okay.
But if you need to lose weight and you use those diets, it's not for me to comment on the pros and cons of those diets. But if you use those diets in the short term, so you're talking about short term, a few months, I imagine.
Yep.
It's not going to harm your liver. Definitely not. Ironically, losing the weight may be of more benefit.
Yeah. Okay. Perfect. Thank you.
So there's an answer for you.
Wonderful. No, that's helpful. I appreciate that. So just to let you know, we've had a hello from Belgium, and we've had a hello from Denmark as well. So
I love it. Good places.
Okay. Question is, my clinician suggested the drug I was on for IVF could have caused my PBC, but did not elaborate any further. I'm really confused, which I understand. So could you explain how this would be possible? There's a question for you.
Okay, I cannot in my wildest imagination think of a relationship.
Yeah.
And I'm not sure that I would accept that
Okay.
as a cause of your PBC. We know even, so I'm not sure how old you are and when that started, but you would have been in your reproductive years to go into IVF. And I cannot think of an IVF drug that could cause granulomatous liver disease or autoimmune liver disease. I'm really not sure if that's, I don't know what your clinician was thinking. You'd have to ask, but so I'm not going to denigrate that answer, except to say I would challenge that answer a little bit.
Okay, perfect. So can I ask you then, in terms of what we know, which is a variable amount at best, but in terms of how we develop PBC, what do we know in terms of potential causes?
So we don't really know. There some epidemiological linkages, and you've got to realize this is a rare disease, so it's hard to do that accurately. And some of this is done in days gone by where PBC wasn't as common. It may have been as common. We don't really know because it might have been missed, a lot of it. There's some linkage to a whole bunch of environmental stuff. For example, smoking is one of them. There's familial. There's lots of reports on family, so genetics, so siblings. I don't have many siblings in my patient cohort, interestingly, but there's published data on siblings. So family, smoking's one of the key things. People have looked at various environmental toxins. And to be honest, a lot of those toxins that were once reported are not widely used today because they've disappeared for other reasons. So I don't think they're a cause of PBC today.
Okay.
So we mostly don't really know. The prevailing view is there's a genomic predisposition, and somewhere on that genome, when we know exactly what it is, so this little bit of the gene, it's not too far. It's adjacent, probably, to a bunch of other closely associated autoimmune diseases like vitiligo, which is that skin depigmentation disease, autoimmune thyroid disease, maybe even celiac disease. They're all closely aligned and will be discovered to perhaps be sibling diseases because of the genomics. And there might be a second hit that happens that precipitates an environmental factor or something that precipitates activation of the disease in someone who has a genomic predisposition. But that's my explanation, and someone may give you a slightly different explanation. Would that be right, Robert?
Yeah, I think that's the general consensus that, basically you need two bits of bad luck. One is your parents, and then two is, something which triggers that.
Yeah, we don't properly know what that trigger is, but
yeah.
So,
and I think, when you look at the immune system and what it's designed to do, I don't think there's going to be one trigger. I think it makes sense that there'll be multiple triggers that start off that.
Yeah.
So
I totally agree with that. Yeah.
All right, brilliant. Thank you. Okay, recently, so the question is amitriptyline. Any contraindications or adverse effects on PBC or the liver?
Not at all. Amitriptyline's, other than it depends what dose you're using it, but it's generally a side effects. The higher the dose you use, it affects the brain, not the rest of the body. No, I wouldn't get too concerned about that.
All right. Okay, that's perfect. That's helpful. Is there a link between PBC and erosive gastritis?
Not erosive gastritis, but there is a strong link to a condition called there's a disease called there's basically autoimmune gastritis.
Okay.
And there's a disease which we've heard about called pernicious anemia that a lot of people would have heard about. It's not the modern term pernicious anemia, but it's hard to get rid of it. So it's an anemia characterized by low vitamin B12 levels. Vitamin B12 is absorbed in the last part of the small intestine. So if there was, for example, some people with very bad Crohn's disease or have had surgery of the last bit of the small intestine may not absorb vitamin B12 very well. But with these people with the stomach disease, the pernicious anemia, humans can't absorb B12 without a specific protein made in parietal cells found predominantly in the top half of the stomach, the upper half of the stomach. And in this disease of pernicious anemia, we get a deterioration and death, which we refer to as atrophy, and inflammation of these parietal cells. So they die and they don't manufacture acid. So people have lower levels of acid in their stomach and they are predisposed to stomach cancer because of that. They also have they have low vitamin B12 levels, and oral supplements don't work. They have to have injections or via the nasal or under the tongue. So it gets into the venous system straight away. And because they don't make this protein because of cell death. And that disease is called atrophic gastritis. It's not erosive. It's just it almost dies. It disappears, the cell structure. And some people call it autoimmune gastritis. There are autoimmune markers in the blood that we measure for these diseases. There's a thing called parietal cell antibodies and intrinsic factor antibodies that sometimes alert your doctor to it, and people usually land up having a gastroscopy or endoscopy, and they have a look inside the stomach and get some biopsies, but they don't usually have erosive gastritis, if that's the question.
Perfect. That's helpful. That's a great answer. So we've had a couple of questions with regard to brain fog. So I'm going to get on my soapbox for a second.
What was that? Sorry, I missed that.
Brain fog.
Okay.
So I'm going to get on my soapbox for a second. So you'll need to forgive me for this. So the question has come from Spain, and we work well with Albi Spain, who's the patient support organization there. And one of the features they talk about is the Spanish clinicians are not tripping over themselves to acknowledge fatigue or brain fog as part of PBC. So we understand that is a thing, and we're working with Albi Spain there to try and improve that understanding and perception. So I just wanted to share that with the person who asked the question. And Martin, you and I will talk about the upcoming summit and what we're trying to achieve with that in terms of sharing knowledge. But the question is, brain fog, is it a thing with PBC? And someone's asking, is it recommended to be referred to a memory clinic for the cognitive difficulties associated with PBC and PBC fatigue? That's a couple of great.
Okay, that's lots of questions. Brain fog is definitely a thing. Now, it's not everyone who has PBC gets brain fog, and they could have brain fog for a whole lot of other reasons that are unrelated to PBC, and it's very challenging that. But there is no brain. It's not only brain fog. It's this inappropriate fatigue and tiredness that our patients get. They really need to have a nap for no reason out of the blue in someone who wouldn't have to just suddenly have a nap in the middle of the day, So that sort of thing is there. The brain fog is not something you can quantify or measure very correctly or properly, but believe you me, it is a thing, and I would accept it as a thing. And it's a thing not only for PBC, for anyone with advanced liver disease. All those things are a thing, but it's more characteristic of PBC. Now, in part, historically, it is because PBC was picked up in women who are really getting a lot older, so they may have slowed down anyway at that time of their life. But we see it in young people diagnosed with PBC. This is a thing that some patients with PBC have, and I have no doubt it's a thing.
Okay, thank you. And
But
in terms of
maybe everyone has brain fog in Spain, and they don't see the difference. I'm being facetious because it is a thing. If you came to my clinic,
no, absolutely, I appreciate that.
now memory clinic, I'm not so sure there's major cognitive decline. If you have serious cognitive decline, there's something else going on, and you should really have that looked at. And you may need, I'm not sure I'm addressing this to you. You may need to go to a memory clinic, but the memory clinic is run by neurologists and people who specialize, neuropsychiatrists who do that sort of stuff. They can't help your liver, and it's your liver that's causing this brain fog. So they won't know about your liver, and they can't help your liver. So from a liver perspective and a primary PBC perspective, you're not going to get a huge benefit out of that. Yeah. It's just not a.
Yeah.
You're not going to get a huge benefit out of a memory clinic, but you might get a benefit if there's another reason unrelated to your PBC.
Yeah. Okay, perfect. That's ideal. Okay, so those questions. So when we do those, and we've done them with various clinicians over the world, and Dave Jones is one of our regular clinicians, and he always talks about the standard of questions that come from an engaged, informed, intelligent patient community. So today's humdinger for you, Martin, which is on Facebook, which is live, is: what is the difference between ductopenia and cirrhosis?
Okay. All right. That's a complex question. I wish I had some diagrams to show you because it would be pretty obvious.
Yeah.
Ductopenia. So when we look at the liver, and I don't have any, I would be nice if I could flash up a slide of a liver biopsy. You have these triads where you have the hepatic vein, your duct, and your arteriole, all in this triad. And in between these triads, you have them all over. You have these diamond-shaped microscopic areas where you have these hepatocytes and what we call central lobular venules. So you have two different blood vessel systems for the liver, and I can't go into more detail in that right now without the correct diagrams. But ductopenia means these little duct branches, so think of them as little streams or creeks, start disappearing. They just disappear. They literally go away because they've been inflamed and they're a bit scarred, and you just see a paucity of ducts. Cirrhosis is where you get around those areas, around these portal tracts where you have this triad. It all gets scarred and fibrosed, and it joins other they bridge out to other portal tracts. So they bridge out through these liver cells and they hook up to other portal tracts, and eventually you form a lobule like that. So you have these little triads that are very fibrotic, and then they try and extend and extend, and they join and they join. And that lobule of scar tissue that traps all the liver cells in is typical of cirrhosis, and you'd have lots of these lobules all over. Your whole liver would have them, and they can be microscopic lobules that you can only see under a microscope, or that can be what we call macroscopic, that if we image someone or we open up and do an operation on the liver, it's very obvious they've got these big nodules, or you can have a mixture of both.
Okay.
Without a diagram, that's the best I can do.
Without a diagram, that is an amazing answer. So thank you so much. Absolutely delighted.
These are good questions. It's amazing the audience asks such good questions.
It's absolutely incredible. I love these sessions. I think
I'm just amazed where you guys go.
So okay, well, thank you. I appreciate that. So we're not going to ask you to recommend any clinicians in particular. However, particularly in Australia, there aren't too many PBC specialists that are flying
Yeah.
around the country. So in terms
So
of
there aren't too many liver specialists, and then within that, the PBC type community is narrow.
Yeah.
If someone I wouldn't name. I'm never going to give you one name in a city. I'd give you a few.
Yep.
Because I shouldn't favor anyone.
Yep.
And if there's a particular city where people need, I saw someone flashed up, who do they see in Melbourne? I can give you a few names.
Perfect. That's really, really helpful. So I'm actually going to ask you, is it worth an email of introduction? So maybe, if you can introduce the foundation to the clinician, and we can maybe make ourselves, aware to them and share our materials and all of those kind of things. I think that would, if you're happy to do that.
I speak about, whenever I go to meetings and I'm with my colleagues and we're discussing PBCs, say at a liver meeting, I will always talk about the foundation. You know that.
Oh, bless you. Thank you.
I'm a great advocate for the foundation. So they look at me, he's the foundation guy. All right, we'll go through him. Certainly in Sydney, it has a higher profile in Sydney only because I talk about it to my colleagues.
Wonderful. No, thank you. I appreciate that. So,
and they're very receptive to it. No one ever gives me any. I've never had any. Well, we're not interested type thing.
Yeah. Okay. Thank you.
You can speak offline and communicate and send you something.
I appreciate that. All right. Thank you. Okay, we're back to Urso again. Does Urso cause hair loss because somebody's hair is snapping and getting thin?
So really, probably not. But there are autoimmune diseases that cause hair loss, and it's just, I don't know you, and it's not for me to give personal advice, but that is something that may be worth discussing with your doctor, because there are associated autoimmune diseases that give rise to hair loss that may be associated with PBC. I've never had anyone with hair issues, and I've not read anything about Urso and hair loss.
Okay, so that's fascinating, and I'm wondering if that is, the awesome weather that you guys have over there, because certainly in Europe, it's a thing where so it's not hair loss per se, but there is that slight thinning, if that makes sense. We're just the textures of it.
I haven't had much complaints, but I'd always at first suggest you discuss with your doctor that there are autoimmune diseases that you lose hair.
Okay,
and you should always have that looked at first, just in case, because you've got one autoimmune disease, you're more likely to have another one.
No, absolutely. So actually, by
the way, we're starting to see, we're becoming more aware, it's not common, of PBC in young women now and pregnant women now.
Yeah.
So just to have it's quite interesting once you start looking, because they're misdiagnosed in pregnancy as cholestasis or pregnancy, which is much more common.
Yeah.
And they're treated in the same way. And then after the pregnancy, they stop the tablet because pregnancy gets rid of, getting rid of the baby, delivering the baby gets rid of this cholestasis of pregnancy at day one. So they stop the Urso, their liver tests are normal, and then suddenly they go absolutely crazy, and they really are difficult to treat patients because they're difficult to bring the disease under control. And we've recently published some data along those lines of PBC and pregnancy outcomes and the impact on pregnancy.
So I'm really heartened to see that kind of data come out. Again, at the foundation, and about the app that we do and all the surveys we do and all of those kind of things. But we have a large cohort of patients in their 20s. So it's great that people are getting diagnosed younger. It's great that they're getting diagnosed much earlier in the disease journey. But I think, and as you say, when you start looking for it, lo and behold, you find it. And so if we can get that kind of data out to more clinicians, so they start having that kind of approach, I think that would be great for the community. So I'm delighted.
It's really hard. You're looking at a rare disease, and then you're looking at a subgroup of a rare disease, and it's hard to get that data published because the numbers are still relatively small,
Yeah.
But we struggled a bit with getting it published, but it's a worthwhile study looking at what we've done as a meta-analysis. So we've collected all the small studies and put them together so we can get a bigger database to look at it.
Fantastic.
And we've certainly made our Sydney community very aware of that.
No, that's brilliant. I'm absolutely delighted you've done that. So thank you. So we've now found two people with the exact same name, both in Australia, that have PBC and are part of this group.
Sure you're not related?
We will find out. Okay, so you spoke about multiple autoimmune conditions. So we've had somebody who's saying tested positive to mitochondrial antibodies, needing further blood tests to determine the titer. So that's the degree of those antibodies. Been diagnosed with SLE, so I'll ask you what SLE means, and then antiphospholipid syndrome.
Okay.
Is it common to have all three diseases?
Not that common, but it is a thing.
Yep.
SLE is people refer to as lupus, so systemic lupus erythematosus.
Yep.
Is the correct name. So most people don't like long names, so they call it lupus. And lupus, a subgroup of people with SLE have antiphospholipid syndrome. I'm not an expert on it. A rheumatologist or immunologist would be. But part of that, you get clots, you get a whole bunch of other things. It can impact on pregnancy, so you need to have blood thinners during pregnancy in some patients. So if you have this syndrome, they often are connected, and then it's really bad luck, but it's not beyond the realms of possibility to have PBC as well. To have PBC and associated SLE or lupus.
Okay, perfect. That's helpful. Thank you. We've got somebody who, and the suggestion is that they have improved their liver test results just by improving their diet, which is great changes and things. So, would doctors, under those circumstances, would they still recommend urso for PBC, or would they wait and see what the liver tests are doing? Any thoughts? And again, this is not.
I'm going to talk to you generally because I don't know you.
100%.
I'm glad you. I hope you listened to the beginning part of my talk, the first question, because a lot of people have fatty liver as well, and that's not good for PBC. It's not good for any other underlying liver disease. So having a good diet and perhaps losing a bit of weight is, for some people, that aren't very skinny, is a good thing. So you've obviously done quite well with that. If you truly have PBC, your diet's not going to fix the primary underlying damage that you're going to get from the autoimmune activation. So you would be best served, I would think, and I don't know you, so I'm giving general advice, you'd be best served by being on urso in the circumstances, in spite of doing very well with your diet. And the two should go hand in hand. So I would encourage you to continue with your good diet. I wouldn't take that away from you. That's fantastic, and well done to you. And it is important if you had fatty liver, but the actual urso is going to stop some of the long-term destruction that the diet won't have. The diet will take away, if assuming you have fatty liver disease, is going to take away those toxins, those different toxins that come from fatty liver disease that would actually enhance the inflammatory process and will aggravate the PBC.
Okay, perfect. That's helpful. Thank you. So I've got somebody asking a follow-up question with regard to Spain. So just again to say that the patient group in Spain is Albi-Spain. Actually, it might be Albi España, but if you look up Albi Spain, I'm sure you will find them. Now, so I don't know how it is in Australia. So this is probably our last question, Martin. So thank you. Over here in Europe, you can get urso in tablets, capsules, 150s, 300s, 250s, 500. You can get it as a liquid, all of those kind of things. So people are asking about the different formats that you can get urso in. We've got one patient who's talking about the fact that they have now and I can't remember if they've switched over to capsules. I've changed from capsules to tablets, and because the tablet is more milligrams, they're not taking as many tablets, so that works for them. So can you just say a little in general about the different forms of Urso that are available and maybe some of
So I can tell you what's available in Australia. There's two brands available. There's the originator brand, which is Ursofolk. There's another generic brand that's come onto the market. Ursofolk sells the bulk of its Ursofolk. There's two size formulations in Australia. There's 250 and 500 that are on our pharmaceutical benefit scheme. So no one's going to import a drug in a different, and there's no liquid formulation.
Yeah.
So you either get 250 or 500, and it's Ursofolk or the generic brand, and we don't have much choices. I wouldn't think the formulation would matter if it's liquid, tablet, or capsule, because it would have to go through some formulary of equivalence through any drug regulatory authority. So we have the Therapeutics Good Authority in Australia. There's a European authority. There's the FDA in the USA, etc. Korea, there's one. Japan, there's one, etc. Just about every country in the world has an authority, and they would want the pharmaceutical companies to show equivalence and pharmacoequivalence in lots of different ways, how it's absorbed, how the drug levels, it's what we call its half-life, etc.
Yeah.
So I think if it suits you to have a different formulation because you get more out of it and less tablets to take or whatever, good luck to you. You know, I wouldn't discourage you from doing that. If I had a liquid formulation available and some of my patients wanted a liquid formulation, I'd be quite happy to give it to them.
Yeah, perfect. That's helpful. Okay, thank you.
That's the way I would understand it.
Indeed. So if there were any questions that weren't answered, or if there's anything personal to you, I would encourage you to get in touch with the foundation. You can email either Linda at pbcfoundation.org.uk or myself, Robert, at pbcfoundation.org.uk. Martin, thank you so much for your time today. Now, I'm going to be seeing you.
Actually very enjoyable. It's nicer to talk to the patients. I'm always giving talks to doctors of various sorts. Tomorrow night I'm giving a talk to doctors about fatty liver disease and end-stage liver disease, and showing them the FibroScan. But this is way more fascinating, and you have very good questions. Seriously, if I'd planned for this talk, I don't know if I would have planned correctly. So thanks for the good question. Kept me on my way.
Absolutely, thank you. Now, we're seeing you in May. Now,
yes.
So those of you that are in Australia never seen Martin before. So Martin's dedication is such that he's coming over to an international event that the foundation is hosting in May. We're going to have clinicians there. We're going to have patient advocates. We're going to have 20 patient advocate organizations there. We've got clinicians from around the world. We've got industry partners who are highlighting their work. And Martin, bless him, is going to be in the plane longer than he's going to be in the UK. And his dedication is such that he's coming over to do that. So firstly, thank you. Looking forward to seeing that. In terms of the summit and what you hope to achieve and the work of the foundation, do you have any thoughts or comments? Not to put you on the spot.
Look, I could talk for ages. So thank you for the invitation to the summit, firstly. It's very flattering. And they're like, from the clinicians that Robert's and the PBC Foundation through Robert have invited, and Alan, there's real clinical leaders that I would have such respect for. It's amazing. And they're very eloquent people, very knowledgeable people, such good thinkers and such lateral thinkers. And people are going to come from different countries and quite different parts of the UK, and they're going to think differently at the summit. But we're going to come with our ideas, and we're going to be put together in these rooms. We're going to have to formulate what we see is happening from a medical side, and through the foundation, we're going to have to link it through what consumers want, and what people with this illness want dealt with as priorities. And hopefully it's going to develop some documentation and real well thought through documentations and sophisticated documentations that the foundation can use and our colleagues can use beyond the foundation, that our medical colleagues will take on board, and because this isn't a high profile disease, liver diseases are part of gastroenterology, and it's a small part of gastroenterology in terms of day-to-day work. There's always less liver doctors than there are general gastroenterologists. And within that liver area, autoimmune diseases are even smaller. So it's really good to see the foundation not only working for the UK, but beyond the boundaries. Someone seems to think the internet's dropped out, but anyway, beyond the boundaries of the UK, and it's amazing.
Right. All right. Thank you so much.
I'm very excited about the opportunity. As tired as I'll be, I know I'll be kept away.
Wonderful. Thank you so much. Okay, sir, enjoy the rest of your evening. It's now.
Someone's asking about doctors in Melbourne. If you email me, Robert, I'll just give you a list as opposed to recommending an individual name. Would be better for me to say these are all top-class liver doctors who would be comfortable treating this illness.
Perfect. That would be really helpful. Thank you so much.
I can give you
thank you. So if you're watching on Facebook,
8 or 9 names usually. Yeah.
Okay, wonderful. Right, 8:30 p.m. over there. Again, thank you for your dedication. Really, really nice to see you.
Good night, everyone.
All the best. Thank you.